the renin-angiotensin-aldosterone system, which we would typically think is just a mineralocorticoid or a salt handling system, that directly activates gluconeogenesis and glycogenolysis at the liver. So those may be people that are they're salt sensitive, and we think of that only perhaps being relevant to the cardiovascular blood pressure regulation, but it might also have an influence on hepatic glucose control. And then one last comment, because I've been talking too much. I would just say, with long-term adherence to a low-carb diet, where people start to see glucose not moving the way they'd expect, or they eat glucose and now the glucose goes higher, people want to use the term physiological insulin resistance, which is a term I don't agree with in that context. I think the better term would be either just a glucose intolerance or a reverse metabolic inflexibility, where the insulin has been down for so long that to a degree they might have lost that first phase insulin release, which are these prefabricated insulin molecules. And now they eat that glucose. It's not that they're insulin resistant. If you gave them a bolus of insulin, you'd knock them out. But they've just been in such a state of fat burning for so long, which is of course synonymous with low insulin, that when you challenge the system with glucose, they're not adapted, where they're not burning it very well. They're stuck in that reverse metabolic inflexibility, where they're stuck, if you will, in fat burning mode, whereas the conventional inflexibility is stuck in glucose burning. But I've said enough, too much. Those are my.
That was all great, relevant to what I was saying. But Rob did raise the point about the heart. What kind of fuel does the heart use? And just to elaborate on that a bit, I mean, the glucose is a minor player for a cardiovascular energy source, especially cardiac energy.
Yeah, that's.
I don't think people are sufficiently aware of how dependent the heart, especially in case of heart failure. The heart really prefers ketones. And
It says it's playing out. Look at this.
I think the SGLT2 inhibitors. I think the SGLT2 inhibitors will make people start thinking about this. When I asked Ethan Weiss, I don't know, 4 or 5 years ago, we were talking about potentially starting a trial for ketogenic diets and heart failure. We got a lot of interest in the Yale system about it. I approached my directors about it. He had to talk to some colleagues.
Right.
So I think there's some interest.
It's off.
But, I agree with you. It's probably the conventional medicine doesn't.
I'm going to reboot the whole system.
Conventional medicine, I guess,
doesn't showing me that it's playing out, but it's not playing out.
So just one clinical comment about the SGLT2 inhibitors is that when people go ketogenic.
Yeah, just refresh their screens after a few minutes.
Yeah, the acidosis.
I specifically, as soon as I get anybody coming in on an SGLT2 inhibitor and they're going to go on a ketogenic diet, I stop that. And if anything, I add a GLP-1 inhibitor, so agonist. Yeah. So that I've had a couple of patients go to the ICU in DKA. But the other, Ben, just if I can, I've got the mic. For me, the holy grail for me is AMP protein kinase. AMP kinase is really the holy grail of what we're talking about here. Forget about insulin synthetic functions, is really energy. And what we're talking about is energy utilization, intracellular energy availability. And that is regulated by AMP kinase. The higher your AMP, it means you don't have adequate energy. You want to get your ATP up. And it doesn't matter how the hell or what type of energy you get into the cell is desperate it doesn't want to starve. So AMP kinase will regulate insulin at a variety of different levels. And in fact triggers, as you know, ketogenesis, NEFA release, which I wasn't as aware of, and I'm becoming much more aware of it. And really what we're dealing with is intracellular starvation and ultimately insulin resistance. Phosphorylation of the GLUT4 insulin receptor is about having a high blood sugar, but you can't get the sugar into the cell. So then the cell's demand by AMPK says, hey, I need ketones, and the liver paradoxically produces ketones in the face of high insulin, of high glucose. On the other hand, when your sugars are very, very low and you don't have glucose substrate going up the portal vein to the liver, that is a reason for glycogen activity in the face of low insulin. But that's not just the final comment. I'm holding the floor here. We tend to think of this as up and down. That's not the way it works. It works more like a vibration, because you have to have some insulin function even during prolonged starvation for cholesterol synthesis, for protein synthesis. So it is a minor fluctuation throughout the day, often diurnally variated by cortisol in people on long fasts. So you've got elevated insulin at certain times of the day and drops at other times of the day. And it isn't just up or down based on whether you're fasting or feeding. It is this continuous feedback cycling, almost like a vibration, that is ideal. And I think we've got trapped into up and down rather than minor nuances when it comes to healthy.
If I can say something about that, there was a point in my talk, I don't know if you had a chance to see it, I was talking about how these different phytochemicals can work to sometimes give a boost, and they do that through AMPK. And I was looking at one commentary paper that has a funny title. It's something like "Welcome to Insulin Resistance Country," and they're talking about smoking, and they had this idea in their mind that it was the paradox that smoking would both at the same time increase lipolysis but also increase insulin resistance. And so they were kind of anti-recommending or saying that this was the problem with smoking, whereas to me, to my mind, this is actually the good thing that's happening with nicotine is it's promoting lipolysis through AMPK. Now, smoking, of course, may be too much oxidative stress, but if you're just looking at nicotine alone, and what they're seeing is this insulin resistance, and I don't want to trigger Ben about that. Maybe glucose resistance is a better name for it, but if you're on basically a regular kind of high carb diet and then you're getting that addition of AMPK, then yeah, you're getting mixed signals. It's not one or the other, like you're saying, Rob.
Namely, and there may be an exception, but I think the only instances are puberty and pregnancy. Yeah, exactly. And so the two P's of physiological insulin resistance, and that is meaning it's
or infection, acute infections. The other
yeah,
one, right?
You're right.
So,
yep, that's an excellent point. Yep,
yeah.
That's like, yes, sepsis can boost that significantly, but I would say that's a pathological insulin resistance more than physiological, maybe, perhaps. But regardless, in the case of a low carb diet, insulin is exquisitely low, and the person, and George Cahill kind of teased this out, I think, with his fasting studies. He gave injections of insulin and the glucose plummeted in these individuals, and that to me throws the whole idea out the window, where I just don't think, and admittedly it is semantics, it is, but I think it does help to have a common vernacular and so I would maintain, in the case of a low carb diet, the glucose intolerance that we see should be called the glucose intolerance rather than insulin resistance. Now, those two things can occur together in actual insulin resistance, but in this case, I don't think they are.
I really
Ben,
like that terminology.
Go ahead, Amber.
I really like that terminology because there are other things that are happening at the cell that have nothing to do with insulin that are kind of favoring fat uptake and disfavoring glucose uptake in the presence of high free fatty acids.
So Ben, I just want to have a little point of contention. So you mentioned in sepsis being pathologic insulin resistance. I'm going to say that I have to disagree. We cause insulin resistance with stress dose steroids in sepsis because we prefer it, because it is a protective. So, and same with pregnancy, right? The insulin resistance is protective. So I think insulin resistance is likely our friend. It is protecting these people in diabetes, right? It is literally, it's protective. Obesity is protective. These high sugars probably have, I don't know if they're friend or foe. They're just like a expected response to the food environment. I don't know if that makes sense. You know what I mean?
Well, no, I think it does. I do. What I would say, where we may be splitting hairs, I don't question that the insulin resistance is an adaptation to the situation, but I do think that it is I would say that becoming insulin resistant, at least in the case of someone progressing towards type 2 diabetes, that is, in my mind, lighting the fuse to almost every other chronic disease in the cardiometabolic realm. So I think it is, fat cells becoming insulin resistant is a way of the fat cells defending themselves. The hypertrophic fat cell is basically saying, I'm too big. If you force me to get any bigger, I will become necrotic.
Dysplastic,
I will make you regret it. So I'm going to become insulin resistant in order to control my growth, and I'm going to start secreting cytokines to try to promote angiogenesis because I'm hypoxic, and these cytokines, some of which will foster vascular endothelial growth. And so the fat cell is becoming insulin resistant to protect itself. In the process, it's secreting cytokines, it's secreting free fatty acids or non-esterified fatty acids. And so in an effort to save itself, it basically spreads this insulin resistance through the rest of the body. The liver is right downstream of that. It becomes insulin resistant, then the muscles, then the pancreas, and so on. And so I say that the fat cell is the first domino to fall, and it falls to try to avoid enemy fire. It's jumping out of the way, but in the process, it bumps into others that suffer as a consequence. So I'm not saying that insulin resistance isn't an adaptation. It is, but it's an adaptation that the fat cell in the environment we're putting it in continues to lose. It's a fight that the fat cell can't win. And so the insulin resistance, which might have had a patina of value and benefit, really ends up just being pathogenic.
Hey, Ben, I have a quick question on that. Hopefully it's a quick answer. It seems that as those visceral adipose cells get more full, they're less resistant. They're more resistant to lipolysis. They're harder to break down. What I'm seeing clinically is people with more visceral fat have way more trouble breaking that down than people with less visceral fat.
Yeah, Brian, you're probably right. I'm sure that's what you're seeing. And again, I meant what I said yesterday, where the physician, I think, always has a trump card over the PhD. And I acknowledge that and will always allow you guys to play that trump card, and I will acknowledge it. All I know is that visceral adipocytes undergo lipolysis, at least maybe in a laboratory setting. They have at least a high degree as lipolysis or capacity as subcutaneous. But what you and I touched on yesterday, there are other variables like cortisol, for example, that will selectively be promoting lipogenesis and adipogenesis, visceral, and thus perhaps, slow visceral fat loss. But they have a fine capacity to undergo lipolysis. It's just, it might need a few other variables to be fixed.
Yeah, it could be the inflammation may be the problem. Maybe that huge amount of inflammation.
Brian, visceral fat is an androgenic feature clinically. And it directly, because I measure testosterone on every patient over every time I do blood work, I'm looking at glucagon, I'm checking C-peptide, insulin, blood sugar, A1C, testosterone, vitamin D levels. So I'm looking at steroid hormones, I'm looking at the insulins, and I'm looking at all the lipids. And I can tell you that both in women with PCOS and in men, visceral fat directly correlates early on in an untreated patient on a standard American diet, directly correlates with testosterone level. And as their testosterone level regulates, that visceral fat goes away, their fertility comes up. And it's regulated because one of the things that insulin does is insulin drives First of all, insulin drives cortisol synthesis. And when you lose that diurnal fluctuation of cortisol synthesis, you've got excessive cortisol synthesis continuously, firstly, and secondly, insulin then, elevated levels of insulin block DHEA from going down the steroid hormone synthesis, opposite in male and female, and you drive DHEA to DHEAS, the sulfated form that is no longer available for androgenic or estrogenic hormone production. And that is almost categorical in my patient population. I can look at a person and tell you what the woman's testosterone is going to be and what the man's testosterone is going to be just by looking at them. So that's the visceral fat. And in fact, there's a really cool paper I've got here. I'm actually writing something on this right now from a guy called Zhu, XU, which talks about the emerging role of testosterone in pancreatic beta cell function and insulin secretion. So that's one piece of it. But along those lines, just to kind of go through this also, Ben, in clinical practice, what I see very often is people coming in with insulins, and I use international units, in the 18 to 22 higher. I've seen as high as 85 units, 88 units of insulin, okay, with concomitant elevated C-peptides. And then some of them are hyperglycemic and some are not. So there is this trend where if you can produce enough insulin.
Rob, can you hear me? Yes.
I don't think, Ben, though, that it's one or the other. I think there's a trend to maximum insulin production capacity. And when you supersede
Yeah,
that,
I don't know where the other sound's coming from now.
GLUT4 receptors.
Yeah, that's what, this is what it is. It's playing out here.
Where you cannot produce more insulin,
Goodness me.
and you cannot then get the sugar into the cells. And those people then are hyperglycemic, and they're in ketosis.
You know, can we come back to that glucose sparing patient that we were talking about that David had, Dr. Diamond had mentioned? Yeah, you know, I just want to hear what people are doing. You know, I know, Ben, you kind of see those people, and Rob, certainly I know, and I just want to get a sense of what you guys do. Brian, I see the same thing, especially if they don't make a lot of insulin.
So there's one other thing I want to put on the table just before we go into this discussion, and that is the work that I did in the lab to get my PhD, which demonstrated in a dose-dependent manner, irrespective of blood sugar level, using an insulin clamp, that the amount of sugar in the bloodstream directly affects endothelial function. And what insulin and glucose does is it affects the endothelial cytoskeleton. The endothelial cytoskeleton is made up of vimentin and actin, and when they get glycosylated, this flat endothelial cell rounds up and exposes underlying basement membrane that is procoagulant. And at the end stages of that, you get macrophage entry and lipid entry. Be that as it may, the greatest danger clinically for us, at least in terms of hyperglycemia, is the cardiovascular effect. And hemoglobin A1C is a great marker of chronically elevated blood sugar, which is indicative of that chronic endothelial damage that can lead to that atherosclerotic plaque building up. So in my clinical practice, I focus very, very heavily on blood sugar, irrespective of cause, because of the cardiogenic effect. That's what I've come to conclude. And that also correlates to a certain extent with CAC score. I want to know what everybody else thinks, and I will even use aggressive insulin management in someone who's diabetic or whatever that insulin resistant word is, but where their blood sugars are elevated, to drive that blood sugar down. And with CGMs, I use an insulin sliding scale. And I'm happy to go toe to toe with anybody on that, because I've tried the fasting route like Jason suggests, and some of these people just can't get their blood sugar down, even though they're fastidious about fasting.
Well, I think the question would become, if their sugar's high, they have really high insulin level at that point, trying to get rid of the
I measure their insulin, and it's often below 4 international units.
Yeah.
So their insulin levels are
insulin-penic.
Yeah.
Yeah.
4 I call it. Below 6 I call it.
It's a relative insulinopenia, right? It means that they've overcome their system. They can't get rid of the extra sugar.
But even with that, the problem then is, and correct me if I'm wrong, clinically, the focus is to bring that blood sugar down, irrespective of cause.
Well, I think my question would be, the gosh, I'm blanking on the name. The Accord trial. The Accord trial.
Yeah.
They lowered the insulin, they lowered the sugar levels, and they had worse outcomes with lower sugar levels. That would argue against what you're saying, wouldn't it?
Well, I mean, I guess you gotta what does it take? What does it take to get there?
Yeah, what did it take? They weren't doing it through lifestyle modification. They weren't using low carb and keto and carnivore.
Correct. And
they were using drugs.
Required is a CGM for accurate dosing, an ultra low carbohydrate, preferably carnivore diet, and then weaning insulin. So what I do is I'll put them on insulin to get their blood sugars down, average in spikes, and then I slowly allow them to wean their insulin utilization. And it's bizarre how that works. Over the course of about 6 months, they are able to come off the insulin that they're on with normal blood sugars. And I don't know if it's a deregulation of that insulin glucagon cycling. I think the last thing to be restored is insulin glucagon negative feedback, probably at a pancreatic level. I don't know. Ben,
do you ever measure the glucagon from that? That's
always,
compelling.
Always.
And what happens? Does glucagon come down?
Yes, sir. It comes down. And in fact, when the glucagon is high, and I use a very low threshold for it, I also use metformin to control glucagon. So that's my management.
That's awesome.
But I've got literally tens of thousands of bits of blood work where we're looking at, and I always do it early morning because I want to see what that dawn effect is. And all of those things, we look at so many different variables, including uric acid as a marker of protein breakdown. So there's so many different things that we look at, and those are the numbers, the metrics that I see in clinical practice. But ultimately, I'm driven, maybe, and the question I'm asking to the group is, am I paranoid about blood sugar?
No, I think it's a reasonable thing. I've really thought about doing that. I'm glad you're talking about it, because if someone's sugars run high all the time, there's toxicity from that. So it's a chicken and the egg, because we want to, whatever word we're going to use, insulin resistance. I don't want to increase the visceral fat or the liver fat with using a bunch of insulin to get rid of the sugar. So for me, it's like, I'm more likely to let the sugars ride a little bit, because I haven't seen people maintain it for a long time. I've seen with that 36-hour fast, I've seen them drop it into the normal range, and I haven't used insulin. But I would now, talking to you, if that was a problem, I couldn't get that under control. But I just don't like the idea of giving people insulin, knowing what I know.
You know, the other thing, I think what we're finding here is that there's a lot of issues. Do we make too much insulin and our body's not responding to it? Do we make too little insulin and our body's not responding to it? Do we respond to that insulin but not make enough? Do we make too much glucagon, excessive glucagon, or, you know, so I think the question becomes is, how do we tease exactly where the pathology is? There's like 6 diabetes that we just described, and they're all different things, right? They're literally all different things. You know, you can see a patient with hyperinsulinemia and insulin resistance. I don't know. Sorry, Ben. I feel bad now using insulin resistance, but you know, like, and I could be looking at I literally am thinking of a patient now who's lean, no visceral fat, and his C-peptide is well below 1 and his insulin is well below 2. He just doesn't make insulin. He's very lean. He's got muscle tissue. He exercises. The only way he can bring his glucose levels down is to take metformin and alternate day fast. You know, it's a tough life, but he doesn't want to take any other medications, and he can do it. He brought his A1C from 12 to 6. That's what it took. He has to eat every other day, exercise every day, take metformin, you know, and he makes a tiny amount of basal insulin, and he has no major response. That first phase response that Ben was talking about, that's gone. He doesn't have any of that.
Does he have MODI? Did you get him checked for MODI?
Yeah, I mean, he had, so the insurance won't pay for it, but I'd imagine something like that, right? You know, if we've done the MODIs, most of them come back negative. Mm-hmm. That's a surprise. You think they're MODI, but they're negative. So I don't. But Rob, I'm with you. I agree that at what point is insulin the right answer? I don't know. You know, certainly I think metformin is an easy yes for me.
Well, and you know, the other thing clinically, I've seen this several times now, is if someone's doing really intense 2-hour workout, if they do a Ben Bakikio type workout, they'll drop their A1C and sugars. I'm seeing that they're putting on muscle mass and they're releasing. I think what's happening, and we talked about it because I don't know why this is happening, but it seems like they're releasing a lot more interleukin-6, interleukin-10, breaking down the visceral fat, and that's helping them. They're running on free fatty acids or ketones more, I think, is what's happening.
Let me interrupt to change the direction a bit, because this is clearly valuable for the clinicians who are kind of dominating the discussion, because I understand you want to manage ultimately your patient's health. And so you're interested in what medication to give them and what biomarkers to assess. But the one thing I'd like to emphasize is we have no idea what the coronary events will occur, whether they will or won't occur in someone on low-carb diet. And I think we have to agree that once your patients go on low-carb diet, there's no science that's ever been done that can tell you when any of those changes that occur to someone that goes from type 2 diabetes to now no longer being diagnosed with metabolic syndrome or type 2 diabetes, the markers go in the right direction in general, but there's never been any study to show a change in coronary events. And of course, you know, my focus is to address the issue of cholesterol. You folks haven't been talking about that, but I think one thing is, it's good that the clinicians care so much about their patients. You, in a sense, want to micromanage their physiology, presumably to optimize their health, not just to change these hormones around. Maybe a glucose of 100, dropping from 150 to 100, it's obviously got to be great. Insulin's got to come down, presumably comes down, but even if it's stable. So I think I just want to interject a little bit to say, we're going at this blind. What you're all talking about makes sense, but realize your baseline of science comes from people on a standard American diet who are given medication, and the coronary outcomes or other outcomes all come from basically drug-treated people who are all pretty much unhealthy. And that's the state of the science right now when you're really looking at what are the outcomes when you're giving these patients medication or not giving them medication, taking them off medication, not really knowing the consequences.
I think I like what you say there, and along those things, because I'm sitting here and I want to go through this with you. In fact, this question was for you, David, but I also look at all their lipid profiles. So one of the issues for me, and I think you and I are in agreement that triglycerides are probably the best blood marker that we have of cardiovascular risk. And the concern also, even though that person is in ketosis with those elevated blood sugars, they typically run very high triglycerides or relatively high triglycerides and low HDL. So not only is the triglyceride absolutely elevated, but their lipids are down. And the paradox is that once I drive that blood sugar down, for a little while their triglycerides go up and then they come down quite significantly. And that's where the ketogenic diet is so important. And I'll just give you, I brought this up as an endpoint because it's an important question. This is exactly one of those patients. And I'll give you her metrics and then I'll give you her lipids at the end. This is early morning fasted, blood glucose is 77, hemoglobin A1C is 4.9, glucagon is less than 6, early morning, and her insulin and C-peptide, C-peptide is 0.57, insulin is 1.8. So, but for a low blood sugar, she would be called a type 1 diabetic. This is someone on a carnivore diet. Triglycerides are 39, HDL is 99, LDL is 399.
What's her height and weight?
HDL was how much?
So her weight is 132 pounds, BMI is 22.6. And obviously she's coming to me now. I've corrected this, but she's petrified because her doctor wants to inject statins in her because of that high LDL.
How old is she?
She is 56.
And does she have any risk factor for coronary disease or any family history of coronary disease?
What do you think her CAC score is? And this is one that we talked about, David, because her CAC score wasn't very high to start with, but right now it's 0. I think it was in the 1 to 200 range, and she's now 0.
So this is where I talk about the science, and I focus on people with familial hypercholesterolemia. I mean, you're talking about people who have total cholesterol of 500 and LDL, which could be 250 to 300. And these are people who are 70 years old and haven't had a heart attack. If they don't smoke, they have low blood sugar. It's extremely rare to see heart attacks in people with FH. This is why I emphasize we need to stop talking about LDL because it doesn't matter. Now, the small dense LDL certainly is a factor, but we know that small dense LDL is produced along with components of metabolic syndrome. So I really try to emphasize asking about the LDL, saying, oh no, it's above 100, it's above 150. The American Heart Association tells you you're in danger. Well, it's absurd. I mean, if you look at all the other factors, this is the cartoon I showed, where the doctor says everything's going in the right direction except your cholesterol is high, so you're gonna have a heart attack. There is no science whatsoever to tell you that a person with high LDL, and frankly, just high LDL and low triglycerides, a person's at extremely low risk. Just those two measures. A person with FH, and there are studies that show this, a person with FH who's got an LDL of 250 with low triglycerides has a low rate of heart disease. And so there's simply no justification to lower that person's LDL by any means whatsoever.
Well, I think the big issue is the clinicians are afraid, like you're afraid you're going to end up in court if there is an event. And they say, doctor, this guy's LDL was 500. Everyone, look what Tim Noakes went through. Look what Gary Fedke went through. They had the science, they had the data, and they lost their lives.
I'll testify for you, Brian.
All right, man. That you guys got it on tape. Record this.
You got it on tape, right?
No, I love it. Yeah, because
I
I love it, and that's that was the same thing as I overcome. As I said, well, that's nice, your coronary calcium, but I'm practicing, and so we had to still look at that, and I use that extensively now, just as a marker, at least to say we're not progressing, right? At least we can kind of look at that from a cardiac risk standpoint.
So
let's get with the psychiatry stuff. We have a psychiatrist analyzing this for an hour. Hold
on. I certainly want to hear from Ignacio, but let's come back to this patient. So can you tell us a little bit more, Rob? You said before the score was 100, came down to, so can you give us a little more color so we can understand this case that you brought up?
Right. So she was a patient of mine. She's a weight loss patient of mine who came in morbidly obese. But and this is another little paradox. She had really, really good or relatively good blood parameters. She had slightly elevated triglycerides. LDL wasn't quite that high. Her blood sugars were in the 90s, not in the 70s. And her insulin was in the, I believe, 16 to 18 range. But one of the things I tell
she came to you obese, so she can't like...
Obese. Yeah, she's lost about, probably about 80, 90 pounds.
Okay.
Okay. So, and that was without surgery. She was not, she wanted to come in for surgery. And I said, hey, let's try a keto diet. She's very authoritarian. So I can trust everything she eats and drinks. But here's there's something I was going to say about her. The interesting thing that I find in my practice is the people that are able to gain weight very easily have the best blood work on average. In other words, the ability to turn sugar into fat protects you from intravascular damage. The people, so if you walk past a donut, this is a saying I use, and you gain 5 pounds, you're less likely to have a heart attack than if you walk past a donut and your blood sugar goes up by 50 points. And that has been, because the paradox, when you see a 500-pounder, you automatically think how sick they are. And yet their blood work tends to be really relatively good until they coalesce at the top. And then they may have whatever you call it, insulin resistance, but they're not near diabetic. A1Cs are not bad until they coalesce, and then they start to go off. But the insulin levels can be in the 30, 40 range.
They've accommodated.
A1Cs are low.
They've accommodated, right? They've basically accommodated. So what happened with this patient? She came to you, she lost 90 pounds, you had a starting CAC, she had another CAC. What happened
The most recent one on that sheet of paper is zero. That's her blood work. The problem is when she goes to see a family doctor, they send her to a lipidologist in Miami who said, you need to come in right away. We need to inject you. You're about to have a heart attack, despite the fact that her CAC score went down. He apparently just ignored the CAC score and focused on the 400 plus
and this is
LDL level.
BMI 22, right? So if you look at, maybe Ignacio could talk about this, because if you look at the data for anorexia, okay, the anorexia data, who the experts in fasting and carb restriction, right? And if you look at their lipid anomalies, they have very high lipids. So if you look at that data for some insight into what this hyperresponder phenomenon is, you can read about the hypercholesterolemia that's associated. Now, would you turn around and tell somebody with anorexia that they should eat less meat and saturated fat and that they should inject the statin? No. And in fact, when you take these anorexia patients who hyper-respond, according to the energy model that Dave Feldman talks about all the time, and you feed them, right? You feed them, what happens to their lipid levels? Those derangements or adaptions, they tend to normalize. So now the question becomes do those anorexia patients need a statin treatment? I'm not sure. I don't think so. I think it sounds more absurd when we talk about it in the realm of anorexia, right? So maybe we can take that scope. So I don't think, if there's no risk in this patient, if there's a very low risk and we know it's diet induced, why wouldn't we just slightly modify the diet if we think that it has to change? If the patient's very comfortable with that number, explain to her what are the potential risks and then let her decide what to do.
You're absolutely right. But it's a scenario we see very, very commonly in our practice when patients correct the parameters that certainly I'm concerned about, but their LDL goes up. And I'm sorry, David had to leave. And we see that it's not unusual for me to see LDL go up as triglycerides come down, as HDL goes up, with HDL being the last thing to really come up decently, and normal glycemic indexes. And that's the challenge, is the convention is to put your blinkers on and look at LDL and treat LDL. And she's by no means anorexic. She eats a ton of meat, but she's very carnivore. And I understand your analogy.
Yeah, I think you got if you go, I meant anorexia in the sense of the energy model, somebody who's carb restricted and potentially time restricted and maybe low fat mass, or now low fat mass, thanks to you. What are the lipid changes that we'll see? And in fact, this is what I talked about right before your presentation yesterday. We presented a case, we haven't published this data yet. We're seeking to publish it, where we've just modestly added some carbohydrate back, a very low amount. And these lipid, aberrations or extremes seem to normalize. And it doesn't take much, with no negative impact on triglycerides if done appropriately. So I think the idea here is why would you give a statin or a medication for what a little carbohydrate could do if you tolerate it? Now, some of these patients say, I don't want the statin and I don't want to come off keto. That's their choice. I don't know what their lives feel like. I don't know what, if they have seizures and,
we document that, we discuss it with them.
Yeah, like I can't tell them what to do.
We don't know the answer. No one knows.
That just comes back, I think, to David's point, though, that the LDL that people are so freaked out about. Well, first of all, it's on statistics that are not on a keto diet. So yeah, if you put some carb, then you're going to go back into maybe the normal range for a non-keto diet. But then the second thing that he mentioned, of course, is that if you actually look at the statistics, yeah, maybe HDL and triglycerides are having some effect that we want to pay attention to, but the LDL, it doesn't even correlate well. It's not a useful measure. It's only an historical, unfortunate convention.
Yeah, I think we've focused on it because the pharmaceutical industry had a drug that did affect it, and that's why we care. That's really why I think, at the end of the day, I agree with you and both David, it's why are we looking at LDL? Because it's a biomarker that the drug companies were targeting, believing that it had an effect, and that's why we're paying attention. Our whole scientific realm is based on the fact that these drug companies have done massive trials to lower LDL. I'm with you. I think it's a distraction, nominally effective,
The other issue, as much as it pains me to say this, Rob's stuff is very important, what he's talking about, because either there's a high sugar, high insulin damages the endothelium. Without that, these fatty macrophages, all that kind of stuff, foam cells are not happening. So Rob's stuff saying that's what's breaking the endothelium. Plus, we know about nitric oxide. We've been talking about that protecting the endothelium. So if we protect the endothelium, we're better off, right? So like Ben said, I said, Ben, what would you rather have, high insulin, high sugar, or high LDL? He goes, it's a no-brainer. I'd rather have a high LDL every day of the week.
Tro, you said something, and I'm very passionate about absolutely not allowing this patient to do this. Ignacio, what would happen if what's the likely outcome if you took someone like this and told them to start eating carbohydrates again in limited amounts? What would happen to them?
To what kind of patient? To an anorexic patient?
Someone who's lost about 80 or 90 pounds.
Oh, we've done it. We've done it, Rob.
My opinion would have been carbohydrate addicted. Long term, what is the outcome when you give an alcoholic a drink?
Well, it will go off rails. It'll eventually, when a stressful situation or something out of context emerges and they get a little bit into chaos, the vulnerability to relapse is a lot higher. And we know this by a lot of evidence, at least on alcoholism. And carb addiction, I see a lot of similarities to alcoholism, especially because of context-wise, because of the environment, the highly obesogenic environment. So this maps quite nicely with what you said before in regards to an adaptive response to what Tro said before. It is an adaptive response. It is a protective response. And especially if we don't mind about the quality of what are the carbs that she might be reintroducing, but I will for sure assess mental stability, and you have a great experience on assessing that, how she will behave. But at the end, as Tro said, it's her decision, and I will follow her up. I would follow her up closely, give her a lot of support, and set up maybe some red flags of feeling of loss of control over her binging or her addiction or her behavior around eating. And that will be my main focus. But I will try to reduce the fear and anxiety that because that's not also good, having fear or such an anxiety maybe for naturally occurring low glycemic load in general. So it's not an easy question though.
Yeah, and I think the other answer, Tro would agree with me, is you have to have a lie detector test. You trust but verify, as I always say, and it's have a continuous glucose monitor on and have it go directly to your phone. Once it spikes, you call and say, hey, what's going on? I'm telling you, do you think Alcoholics Anonymous had that tool? As soon as they took a drink, you say, hey, what's going on, Tom? Having a hard night? What's happening? Could you imagine? So that's what we have. That's the advantage we have, because I can call someone and go, hey, your sugar's been high. What's going on? Right? My husband left me. Okay, let's talk about it. How you manage your stress, like what we're all talking about. And I think that's a huge thing. Hey, I want to transition because we have two smart people here. Because this is something I've seen clinically. Tro and I have commented on the podcast. I've seen people go to the carnivore diet. Depression, anxiety, stress gets better. I don't know the mechanism. I think I know now, but it is remarkable.
Addiction.
I've seen it. And I think that's part of it. That's a huge part of it for sure. But I think there's more to the story. So I would love to see what you think is the mechanism of why bipolar, stress, depression seem to get better with the carnivore, even more so than on a ketogenic diet.
Are you asking me, Brian?
Yeah, Amber, I'd love to hear your opinion, and Ignacio, I'd love to hear what your view of what the mechanism was. I don't think there's an argument that it happens. I think I see it clinically, so I know it happens, but I don't know why. But I have an idea.
I would say there could be different cases, but definitely in my case, I was on a low-carb diet for 12 years while my bipolar was progressing in severity, and there's no question about the quality of my diet during that time. I was on an excellent diet, and I was not the kind of person you would consider addicted. So you've got to, in my case at least, throw away any kind of hypothesis that's about kind of bad eating from that kind of point of view, because I was eating salads and cabbage, and it wasn't anything to do with that. So when that happened to me, I was lost for quite a while, because I thought I had been quite convinced by reading literature about the healthfulness of low carbohydrate diets that was the key to everything. And so my first hypothesis was just, I had to get the carbs that much lower. But as time went on, I stopped believing that, because I started looking at just more effects of plants that it really took me a long time to even be able to imagine that there could be something bad about plants. And I don't necessarily think that plants are bad for everyone, but I think that there must be some kind of vulnerability that some people have. And I think the best hypothesis that we have about it has to do with barrier integrity. So there could be like intestinal barrier integrity that's allowing more of the toxins from plants to come in, toxins that we would normally, it would just bounce off and it shouldn't bother us. We could take the good out, we let the bad go. That's how your immune system's supposed to work at every level. And anything that's affecting barrier integrity at the level of the gut can be also affecting barrier integrity at the blood-brain barrier level as well. So I think it's an immune system problem. I don't know what the exact mechanisms are, but I think that the carbohydrate aspect of it has probably been a distraction for that kind of disease condition. I mean, the low carb helps, but go ahead.
Can I add some? I think you're onto something here. I've seen very compelling mouse studies showing that all of the seizure prevention comes from the microbiome, at least at the level, when they deal with mice. So I think you're onto something with regard, and fructose we know destables the gut. There's some animal studies showing that it increases permeability. I think you're right there. It could just be that the low carbs favor a different, lowering the carbs may favor the flora to change. We know that does change. I think you're right. And then those ketones seem to have a central mechanism. So possibly a combination of both the intestinal flora, the intestinal permeability, and then maybe these centrally acting ketones. I'm gonna let smarter people talk now.
No, I think you're right, because the ketones definitely have a beneficial effect, and we see that. I mean, we see all kinds of neuroprotective things, obviously, right, from ketone bodies, and what was really striking to me when I started a carnivore diet is that all those symptoms went away like almost overnight, and my ketone levels were not higher. In fact, they may have been slightly lower, but I was still ketogenic.
Was
But
your
then we
blood
do
sugar
see
lower, Amber?
my blood sugar is usually, I'm like your patient, like it's in the 80s normally, fasting. Yeah.
Because one of the theories that we have is related more to inflammation and osmoregulation, in that the glycolytic pathway requires a lot greater, it's much more hydrophilic than the beta oxidation pathway. And one of the things that the brain is in a closed box, and both inflammation and glucose as a dominant fuel source, because of its hydrophilic nature, increases pressure, increases volume. And both of those create a somnolence and an increased inflammation. We know the pathway toward dementia and Alzheimer's is a common inflammatory pathway, whether it's viral or other sources of mediation, and a lot of work is going on into that. So I just wonder if the issue is with glucose, both in an osmoregulatory perspective, as well as from an inflammatory perspective, and fat being a decreaser of that global inflammation. But there's certainly an addiction side as well.
Ignacio, are you seeing stuff in your practice as far as like a low carb versus carnivore, or have you seen that any difference in mental illness?
I don't have like an statistical analysis about it, but with those patients that are mentally predisposed to go to a more carnivore-ish approach, trying to reduce some of the potential culprits of glycemic instability, I see good results. I see that kind of like a quite balanced referral in regards to satiety and reduce of the satiety and feelings of control, proportionally increasing as long as anxiety decreases, because the sense of loss of control is very sensitive among these patients. And when they see that they can eat, perhaps when they turn into a more carnivorous diet, they sometimes, after a little bit of time, especially if they are not fat phobic and they eat the appropriate amounts of fat, their satiety perception, their subjective report of feeling satiated in regards to temptations and the continuity of their diet, that improves a lot. And that, of course, we are humans, and that increases self-esteem, sense of being in control as opposed to controlling what they are eating. And I give them a lot of loose leash in regards to how much they can eat, and that also releases a lot of tension. And of course, if you minimize glycemic excursions, especially among those patients that, like Dr. Cywes said, in regards to they go buy a donut and their sugar increases, and that's something that also happens in alcoholism. There are polymorphisms that make alcoholism also run in families, because there's a larger opioid response to alcohol. So the proclivity, the tendency or the vulnerability of that specific person is higher. So it is very important that we go with those patients into periods of more, maybe being more stringent with what they are eating, but also trying to being flexible in regards to what they might or might not include. And if you approach it as a learning process, as a learning curve, all of those times when they eat something, let's say most of my patients don't wear a CGM. That is my dream, to follow Ann Childers' work in regards to everything that she's seeing with the use of CGMs, because it will give us a lot of, if they write down how I'm feeling after this, because I do all that clinically. It's like, okay, how did you feel? How did you sleep that night? How were with your spouse? Did you feel like doing sport afterwards? I try to help them tie together what they ate and how they felt, and maybe not just that night or that afternoon, but a couple days after. And let us not forget that both hypoglycemia or relative hypoglycemia and hyperglycemia are both HPA axis stressors, very large stressors, or prepotent stressors. So if we are, you ask about stress, anxiety, or mood instability. With those patients, I try to be a little more stringent and trying to be able to walk them through a progressive incorporation of all of these patterns. And that's why I emphasize sleeping well. It's the first step of the game, because the day after they will be stronger in regards to what I see, those hypothalamic drives. They are anxious from the core. They are nervous. They are in the search for something. And this is, if we don't calm down the most archaic structures, our prefrontal cortex is never going to win. If you are on a quest to eat something, get out of the way. I mean, I will bite your hand. And this is what overall what I try to do. I try to set up a wider framework of reference and trying to say, okay, how many meals are we going to have in a month, or we had last month? How did you feel overall? Where were your high points, your low points? And try to tie that to, maybe that didn't have to have it didn't have anything to do with food, but most often than not, it has. Or a stressful event, or a stressful eating, merging, cortisol rising, sugar dysregulation. It's all part of the same scene, and it's a complex cause and effect.
Yeah, you know, the way I've looked at it is this. It's like it's what we've told the patients, just exercise more, eat less. So it's like they're drowning in the ocean. You say, just breathe more air than water and you'll be fine. So what we're doing is we're throwing them a life preserver to hold on to. They're in a panic mode. When they can get onto the life preserver and they know it's there, and even though they're in a bad situation still, they're not drowning actively, we get that stress stabilized. When you do, that's why people aren't binge eating and they're not stressed out. They're not tense. We're getting the hormones stabilized. We're getting them knowing they're not drowning anymore. They're on the right path. They get emotionally better. But what's interesting, I was reading, and I think Nick's paper and gosh darn it. Why am I blanking? My good psychiatrist.
Yeah, you got a cute baby. That's why you're blanking.
Yeah,
Rob's
you got
a cute baby. There's no way you're gonna win that one.
Nick's paper. So Nick's paper. When these kids who are obese as kids have this increased likelihood of bipolar disorder and psychiatric schizophrenia. So you go, could it be the visceral fat? The visceral fat gives off something called TRPBR2. TRPBR2 goes to the brain, causes anxiety, causes increased appetite, does all kinds of crazy stuff. Interestingly enough, if you block this TRPBR2, it blocks a cytokine storm. Interesting, right? All these people who are dying of COVID. And so you go, wow, this inflammation in the brain, all these things, but all that visceral fat is sitting right on top of that gut microbiome that you're talking about. So it may have some hormonal local effects. As a matter of fact, like I started to say, that epicardial fat is way more dangerous than even visceral fat. That's your worst resort. When you start putting fat around the heart, it's not a good thing. And so, you know, this hormonal thing and how much
Brian,
does that affect our brain?
Is that causal or is it associative?
I believe it's, I don't know. Don't quote me on it, but I think it's causal. They said if the more epicardial fat, the more fibrosis you get of the tissues. And it makes sense with regard to the more hepatic fat, the more fibrosis, right? Like you said.
I just can't find anything that makes that, because this is what we talked about earlier. I cannot find a pathway to make that causal. I understand the association, but I think the fat is there for the same reason the heart is being damaged. The fat isn't damaging the heart, but that's kind of the pathway that we're looking at.
Well, hold on. Can I
at least associated?
Can I make a slight correction? I think what's happening is once once there's adiposity and there's a accumulation, I think there's a drive to keep accumulating, and so the harm comes from the obesogenic environment, right? That harm comes because we don't have a environmental shutoff. Right. I think that it's a mismatch. Right. So I don't know if that makes sense.
Here's the other side of the coin. And this is the other question. Maybe I'm controversial, but I know Sean Baker, how many death threats he gets from vegans. I don't know if it is something from the diet or whether it's ideology, right? Because
it's diet.
no carnivore.
No, it's diet. Brian, it's definitely diet. The plant-based diet is associated with depression. It's like insulin resistance is associated with psychosis. I mean, the mental disorders. If you look at the associate, they have, I'd say it's not. It's absolutely not. It's not an observation. I'd say you have enough cause to say that it's something meaningful.
Definitely talks with choline and different macronutrients, micronutrients that can affect this, right? Like depression. Like vegans who eat eggs will do, if they were eating eggs, it seems that they do better from a mental standpoint. So vegetarian, what I'm saying is, I don't see the same depression, anxiety, but pure vegans, I see it, anxiety, stress, like all kinds of stuff. And so that's something we have to look at, especially right now, post-COVID or during COVID, because our suicide rate's going through the roof. This is something no one wants to talk about, but a lot of it is this social isolation, increased visceral fat, stress, so many huge factors. But this is something, I mean, we look at all-cause mortality, not just one disease process. And this is the concern, is like, gosh darn it, because the world trend with the reset and all this is going towards a vegan diet, right? They're pushing this plant-based, and if we're causing mental illness like we've never seen before in depression, that's what I'm concerned about. Literally, like, I don't have a problem with people wanting to be vegan. I'm just saying there are consequences that we need to look at. Ignacio, I'd love to hear your sense of that, if you think I'm off.
If you saw my talk, I kind of like introduce a little bit something that I've been very passionate over the last few months in regards to personality assessment. It has been a topic that I loved for many, many years, and I'm trying to get a deeper sense into the relation with temperament, with biology, and all of that, and the stability of each personality over time. And what I've seen in my personal experience in my office and in my own environment, it is that there is a tendency to have there is a specific part of the population that is more vulnerable to the vegan and compassionate message, and that constitutes a large proportion of the population that adheres to a most vegan or vegetarian diet. And even though it's not the totality, and it is increasing over time, it is also in a specific segment, a socioeconomical segment of society. It has a huge ideological component, and it's usually among most, let's say, with people that usually believes more in a cooperative environment and are more compassionate. And when there's this ideology, you will defend it. I think that most of the hate that someone like Dr. see that they have a low resolution explanation for the evil occurring around the world, causing the pandemics, being the genesis of most suffering among the world. So they have a strong reason to defend what they are doing ideologically, and with all of this health propaganda that for a girl, for a 16-year-old girl, since she was born, there's the vegan agenda. It's been, let's say, like mainstream for the last 15 to 20 years. It's been increasing and increasing and increasing and getting a lot of exposition. So it will be, and they get sometimes the vegan or the vegetarian honeymoon for maybe depending on the prior health. But what worries, but after that it goes on dips usually, because there's such a small percentage of vegetarian and vegan population that follows it and try to address everything very, very seriously and do the checkouts, because most of them, the main problem is that they are relying on grains and cereals and sugar, and they don't cut on alcohol. So it is not an easy topic, but there are very strong ideological position, and when the ethical argument gets in the way and the health evidence is so muddy, it is a perfect storm.
You got me
And
fired up,
What I worry
Ignacio.
about. Yeah, me too.
Yeah,
You got me
excellent
fired
stuff,
up right
man.
now, because you know what, Amber, just if you allow me 1 second.
Go for it. Yeah.
Yeah. So I think what you described is that adolescent, typically female, but now we're seeing it more and more in the men. In fact, the eating disorders are booming in the men. Okay, they're preying on the body image of these young adults. They are preying on their thin idealization. You know, this culture of health, and they're promising them, you know, a moral superiority, and they're leaving them with nutrient deficiency in very formative years. Meat improves IQ, meat prevents stunting in children, you know, and it's meat eating is associated with, you know, more nutrient density in the diet, less nutrient deficiency. I think it is a very dangerous, you know, place we're in when we take a population that's ripe for mental health issues and give them a diet associated with mental health issues and tell them this is the best way to go. I think it's a terrible, there's bad things to come.
I agree with all of that, and the only thing that I wanted to add is that when you're talking about that ripe time for the development, it's not only the development of them, but it's the development of the next generation, because those are the years that they're building, especially women, they're building up the stores of nutrition that are directly going to their baby that they're going to have in the next 10 years. And it's just, it seems like a crisis waiting to happen for the unborn children who are going to be bearing the consequences of it.
Hey everyone, you know, we had some technical difficulties, so I'm actually now being able to see the questions. Doug had some audio, so he can talk to us to tell us or give us the question. So let's jump into some of the audience questions real quick, unless someone wants to finish. Is there anything else pressing on this topic?
Can I just ask one quick question? Amber, you threw something out, and I'm going to put you on the spot here. You mentioned, and tell me to just go jump in a lake. Or the
I'll
Atlantic
jump in a
Ocean.
lake, Rob.
The Atlantic Ocean is just outside my door. I'll go jump in that. But you mentioned that you have bipolar disorder.
Yes.
And I have a huge volume of bipolar patients. And we're actually going to be doing a podcast with one patient who successfully, you don't get rid of it, but controlled his bipolar disorder by doing a prolonged fast and then going carnivore.
Mm-hmm.
Could you, because I'm very intrigued in this, and I know there's going to be a lot of people out there that are, could you share a little bit of your personal story in that regard? I know you've done that before, but could you just share the value to you of this way of life in that regard?
Oh, sure. Well, I mean, it completely gave me my life back. But the progression for me was, I was diagnosed with depression when I was 20, and I was on antidepressants for over 10 years, and there was no real relief. Like, I was considered to have major treatment-resistant depression. And then I had somebody recognized that I was having a hypermanic kind of response. In retrospect, I think it's because I changed antidepressants. I went from I guess I started on bupropion instead of Prozac, and that might have had to do with starting to have these hypomanic episodes. And from that point, well, then I was diagnosed with bipolar type 2. And I was really happy about it because I thought, oh, well, this is the reason that I've had so much trouble all this time. I just never had the right diagnosis, and now that I've got the right diagnosis, I'm going to get the right meds, and everything's going to be okay. But it actually it spiraled from there because the medications that I tried, none of them helped me, and all of them came with terrible side effects. And then the disease itself was progressing, kindling, I guess, because the phases were, the components of the phases were getting out of phase, so I would have like the excitedness, but it wouldn't necessarily be with euphoria, so then it would come out as like anxiety and everything, and then the cycles were getting more and more rapid until they were actually getting to be ultradian within one day. And so it was a nightmare, and it was then, at that point in my life, that I happened to find the carnivore diet, and everything stopped in its tracks. And you know, my whole life was really falling apart. My family life
No one
was
can.
extremely stressful, and I just, from that point, I was able to put my life together back in it slowly but surely, and start to have hope again, and stop having depressive episodes, and stop being dependent on medications which weren't helping me. I just can't even, I can't overemphasize what a difference it made to me. I'm extremely lucky. I wasn't looking for that with the carnivore diet. Back then it was 2009, and all I thought I was going to get was some weight loss, and it just completely changed my life.
Yeah, that's awesome. That, I mean, that's the important thing. As a primary, that affects everything: mood, depression, anxiety, all that. So that's why it's such an important component of what we're talking about, because that affects how people can stick to a weight loss program, or metabolic health. It all goes together, and I think it's really important. The first important question, Ignacio, what are you drinking? Is it yerba mate?
Yes, it's
All right.
yerba mate.
Look at that. Okay, so now we know the answer. They were asking how strict of a carnivore diet, but I know you're dang strict, right? I mean, are you doing, Amber? Are you doing like organs? People are curious about that.
I sometimes eat organs. That's been kind of most of the time that I've been on a carnivore diet. I didn't eat a lot of organs, and then I went through more of a big phase of organ eating in the last couple of years. But yeah, it comes and goes. I eat them for pleasure. And yeah, I'm pretty strict. I mean, when I cook at home, I don't even use spices, although I will, as I mentioned on my Q&A, I will have them if I'm out to dinner or something.
How about ApoE4? Does anyone want to tackle that? ApoE4, more saturated fat and fasting for better health?
I would just say to that the effect that I've seen people talk about is that when you have ApoE4, you're more likely to get a high LDL response from saturated fat. And so that if you don't think that LDL causes heart disease, then there's nothing to worry about.
How about MTHFR? Sorry. Subgroup analysis on vegans with and without. I don't know. I don't know anything about that.
Yeah,
I figured that would be
on my YouTube channel on that, Brian. And if you own shares in a company that makes products that treat it, knock yourself out. Buy as much of the products as you can. Other than that, or if you've got a little bit of extra money you don't need, go ahead and buy all the products. It has been popularized when we got to do all this home kit genetic testing, and a few unscrupulous people leverage this gene variant, it's not even an abnormality, gene variant, to capitalize financially. It is absolutely irrelevant. I spend quite a bit of time looking at homocysteine levels. I look at folate levels all the time. It is completely irrelevant in human biology, particularly when it comes to people on a ketogenic or carnivore diet. And I'm pretty adamant about that. And I have personal experience in my office because I looked into this pretty hard and could find no evidence to support anything other than the economics of a gene variant that a lot of people share. I was very careful about not being strong-worded there.
Yeah, we know that. Dr. Loh, welcome. Thanks for joining us. It's good to have you.
Thank you. I'm on call, so I have to answer something.
Sorry. No problem. Just jump in whenever you want.
Thank you.
No problem. All right, let's see here. There's a question about depression as brain inflammation. I think we have good. I think we have good data. I think that's part of that's at least a factor in my opinion. I would love to hear from Ignacio. What do you think as far as brain inflammation and depression association?
Well, data, at least clinically, has been very consistent in regards to clinically and with interventions in regards to the heterogeneity of depression. In my first talk in West Palm Beach in 2019, I posted a work from a research done in the Netherlands by Dr. Brenda Pfennings. She's on the frontiers of studying the correlations of diet and depression. And she clearly cuts trying to find this heterogeneity, because depression, what is depression? That is a symptomatology. That is something that we feel, and it's categorized as depression when there's a cohort of symptomatology that coincides. But in the clinical practice, there's many different types of situation that can be called depression. And what she found was like a clear cut on this more melancholic, early childhood trauma, tabacism, more female-laden, more charged with neuroticism and psychosocial stress and psychological stress, and that kind of conforms what would be called a typical depression, with loss of appetite, kind of not wasting, but losing a lot of weight, losing appetite, having a lot of insomnia and sleep disruption. And on the other hand, and this is what I see the most often, is this immunometabolic features of high CRP, high IL-1, high TNF-alpha, and that it is very clear that that immunometabolic profile is the one that does the best, of course, with the diet, with high comorbidity, with obesity, with increasing the appetite dysregulation, metabolic syndrome, glycemic instability, and this is the patient we've been talking about the most. I mean, this is the typical in between those 88% Americans that are metabolically unhealthy. Maybe they are one stressful event from even losing the mood balance, let's say. And what drives me the most is trying to find out those patients that maybe don't qualify for a classic depressive cluster, but they go about their days with lethargy, with apathy, without being able to harness that initiative to face things in their lives. And maybe they are financially doing okay, they have their family put together, they don't have any other major stressor, and they are maybe subclinically depressed and not being able to get organized around how to put their health back in place. With those patients, I have the most return on investment in regards to their change, because with a fasting schedule or a time restricting eating, where we manipulate together the fasting and eating schedules and sleeping and vigilance balance, those patients a week or 2 weeks later, when I have the first follow-up, their faces are light up. They have a different attitude. If they were 70 to 80% compliant, and that's unseen with any antidepressant. And if we give those patients an antidepressant, and if we are not aware of the continuum of hyperinsulinemia, inflammation, and that is kind of easy to assess in our clinical practice. You see them because of their personal history, their family history, their context. If they have any hyperinsulinemic stigmas like acanthosis nigricans, central obesity, and maybe they are not present, but when the first labs come down, I always explain with them very clearly that now classic Jason Funk's explanation in regards to the appestat, in regards to how they will start seeing a reduction in their insulin levels, their inflammation levels, their glycemic, a more stable glycemic control. And those patients, when you kind of like clean out all of those clinical aspects, maybe related to inflammation, well, you can start talking about other maybe psychosocial stressors or how they want to design with the newfound confidence in that they are effective when they are doing something, and they feel that they found the solution and they start losing weight, and those first 3 to 4 kilos that maybe they lose in the first couple of weeks, you tell them that, of course, it's not mainly fat, but you tell them, but they come very handy because motivation is crucial. And motivation and what it's their main goal. We tell them, or I usually tell them that weight is going to be a goal, but it's going to be a proxy of their one proxy of metabolic health. But there are a lot of other things from subjective quality of life in mind that for me as a psychiatry are crucial, and those are the ones I'm after. Always, how are you feeling? What are people around you spontaneously telling you? And they're telling someone that I didn't say anything about what I'm doing. They say, I've noticed that you're calmer, that you're more patient, that you are not sweating as much, that you are sometimes are objective things, and sometimes it's like a feeling, a perception. And in psychiatry, subjective quality of mind for me is crucial. Now, my dream is to see how we can transfer all of that we are seeing in our offices and the gratification that we feel when someone goes over that hurdle, that initial hurdle, and maybe even tapering down medications, and that's fire.
Well, I think from a clinical standpoint too, look, exactly what you're doing, this is why we all have to work together. When we have poorly controlled diabetics, depression is a huge factor, anxiety a huge factor. So we said, well, they got depressed and anxious, so they stopped taking care of themselves and they got this way. No, it turns out it's the other way. They had poorly controlled sugars first, and then they got depressed. And then so this visceral fat and all this. So when you're depressed, what do? You eat because you're depressed, right? Your visceral fat makes you hungry. You eat more. Your insulin's high. Your triglycerides are high. And all these things that we get into this total disaster from a mood. So, that's one of the things. Us primaries are treating the metabolic disease and we see the mood getting better. You're treating the mood, you're seeing the metabolic disease. See, we're looking from our area of expertise, and that's what's so great, because we see it and go, this shouldn't be working. I remember thinking, this is crazy. They're happy and they're seeing the sun and they're not suicidal anymore. And you think, wow, that's crazy. There was a question, Ignacio, with regard to, do you just stop, do you slowly taper the medications down, antidepressants, when their mood's starting to get better, or how do you handle the medication aspect of that?
That is a great question. I have an internal protocol in regards to, I individually assess how I'll do it. The first factor, the main factor in psychiatry to tamper down a medication, it's patient's fear and predisposition to get off medications. Because if they are afraid, especially high anxiety level people, they are afraid that if we take down medication, they will get worse, or they will lose their newfound stability. I have to first assess that. That's why I always build a one-on-one relation, strong relation, because those are hard goals to obtain. Release the safety net that for many patients medications imply. But if they are with me right now, like after 6 or 7 years working with diet interventions, if they come to see me right now, they come sometimes for diet wise, for weight loss, but after 5 minutes they start talking about how bad their mood is, and it's the first time they see a psychiatrist. So I see this I see myself as a screening. Mainly, that's my main mission, is like to screen early on potential conditions that might lead to a depression further on. But in regards to medication, it depends. Benzodiazepines, I try to lower them down as fast as I can, because they start to wake up. If they are less anxious, I try to follow like their results with lowering bit by bit, giving them a lot of confidence. It depends on what benzodiazepine we're talking about, but with clonazepam and alprazolam, I try to get them off those as fast as I can, because of the hippocampal effect, the sometimes the apathy, the bradypsychia that sometimes comes along with it, and the potential cognitive impairment down the road. With SSRIs, especially the one that fluoxetine, that is the one that Amber mentioned. Fluoxetine is one of my clinically proven. It is the one that I prefer in those cases that I might even have to implement a drug after a while. But I see drug prescription, or diet prescription, as a framework because if we are effectively going to prescribe a medication, if your brain is not inflamed, if you're doing other things in regards to the HPA axis, and if the person is it's compliant with the diet-wise and sleeping in their hours, I sometimes try to tamper it down in a course of 1 to 2 months, progressively, like 25% at each time, at each follow-up. But it's very individual. There are some people that want to jump right in, and they do a faster tamper down, and they get very good results, and everything is going well. So with those patients, I invest a lot of time in prevention, in relapse prevention, saying, okay, this is an exploration. We're going to try to take it down, and we'll see how you feel. This is not magical. It is not the panacea, especially for the most severe conditions like type 1 bipolar disorder, like long-time standing depression, like dysthymia, that there's some emphasis on the mitochondrial function among those patients, and the inflammation spectrum. So I first try to address the low-hanging fruits in regards to what they can do, because most often than not, they still drink soda, they still go to bed at 2 or 3 in the morning. In regards to antipsychotics, the most frequent use for antipsychotic is for insomnia. So when you use olanzapine or quetiapine or aripiprazole, those to lower tachypsychia and rumination and thought racing at night, even though it's a small doses, those I'm also able to lower them down to the minimal dose. It is kind of hard to tamper down psychiatric medications, but the bedrock of the medication talks is doctor-patient relationship. As I see that I'm sure you all agree in regards to the clinical outcomes. If you are out there and you support them, like Dr. Cucuzzella also said, it's like, all of my patients have my phone number. They are very respectful, but sometimes they just a simple word, you're gonna kill me. I had a party and I ate 2 slices of pizza. It's like, did you enjoy them? It's like my first question. It's always my first question. And how did you feel afterwards? I try to make the most out of each event or each fix, as Rob would say. So, but it is a lovely time to be working in this field.
Yeah, that's really great. I think that's important to address it and acknowledge it and say, okay, how do we do it different? How do you handle it next time? What could we have done different? And so we find they don't do it again. They figure it out. They go, yeah, I can't be alone with food, or whatever it is, So Dr. Loh, how do you handle this stuff, like with regard to mood? Are you seeing the same mood and anxiety, things like that, improving with dietary change, lifestyle management, and tapering medications?
Yes, obviously. And along with the inflammation, I think we also have to acknowledge that there is decreased blood flow to the brain. So in people with obesity, it's just, a very recent study came out, I think it was August of 2020, and they had scanned 17,000 brains. So that was not a small study at all. And basically, globally, there was just decreased blood flow to all areas of the brain, right? And if this is persistent, I think that's going to contribute to brain dysfunction as well. As a result of obesity, we see shrunken brain volumes, we see decreased gray matter, and that's quite well known. Becomes pretty obvious if you look on MRI. So I think that definitely, goes together with the inflammation that's going on in the brain. And also poor endothelial function, if we're looking at blood flow.
I wanted to say a quick thing about inflammation, coming back to the original question. It's just the word inflammation, sometimes I think we use it in an incorrect way because we think of it as some kind of outside action. But when you hear the word inflammation, what you're really hearing is an immune response. And the immune system responds to not only infections, but damage. And so when you say, depression is associated with inflammation, what you're saying is it's associated with damage that your body's trying to repair by putting that inflammation in there. So the causality is very often, yes, of course, when there's something going wrong with the brain, you're going to see physical damage, and therefore you're going to see inflammation. And when you see then some intervention happen that makes the inflammation recede, that means the need for repair was going down. And so I just wanted to make that point about that word.
Yeah, and that's critical. That's what we're talking about. That would damage the endothelium. Also, we're seeing inflammation there. So the causality, that's something we have to look at, and that's an excellent point. Dr. Sean O'Meara, we were talking recently because of what I was seeing with visceral fat, and he's showing data that as the visceral fat decreases, intra-abdominal muscle mass goes up. So it seems that there's some inhibitory factor from visceral fat itself, which is interesting because sometimes we don't see weight loss, but we're seeing that visceral fat dropping. So that's an important thing for educating patients to not give up right away. Also, he showed data with a low-carb diet that, as you're saying, that increased blood flow to the brain, and it may be partially nitric oxide changes also. Interestingly enough, in the same study, they found erectile dysfunction improved or resolving after years of problems. So that's another good argument for low-carb ketogenic diets. Oh, and Dr. Loh, they were asking what program you use to record your lectures. You're way better than all the rest of us. So.
I use a green screen and then pulled some strings to get someone to put the slides on. So
we might need your help. Hey, also there's a question about ultra-processed foods. Are they different physiologic responses compared to real food?
What do they mean by ultra-processed versus real?
Meaning ultra-processed, meaning like, I would assume they're meaning like Pop-Tarts, chips, crackers, that kind of stuff, as opposed to eating a steak, chicken, fish, or maybe even rice or something along those lines.
There has been some research showing that if you take carbohydrates in particular, grains in particular, I think, and you break them down to the point where it's at the acellular level, that you can feed the same amount to, well, in rodents anyway, but just because of that difference in refining, you will get more obesity as a result. But I am shy about the word processed because I think it gets over-applied. So for example, you could say cured meat is a processed food, or you could say a hamburger is a processed food, and just need to be really careful about what you're talking about, because I don't think that there is the same kind of literature with experiments showing that if you mince up meat, that it has any kind of effect the same way that it would if you're talking about a grain and breaking up the cells.
Yeah, Dr. Agnes Ayton has some great data on this also. Basically, she's showing people are binge eating on, there's stages of binging on different processed foods. As saying that most people who binge aren't going to eat a bunch of broccoli to binge. She was saying it was basically 100% of the time it was on ultra processed foods like chips, crackers, ice cream, things like that. Rob, you're the addiction guy, man. You're the one who taught me all this stuff. Do you have anything to throw in on that?
Yeah, I think looking at the biochemistry and all that kind of thing is bullshit. And the reason it is because I don't consider the biochemistry of what I'm eating when I'm looking for something. I've got my favorites. When I was fat, it was M&Ms and ice cream, and the starches and things didn't matter. I've got some patients who love the starches, some who love the polyunsaturated fats. I've got some people that love beer and some people that love whiskey, but they're both alcoholics. So I really think that understanding the science is more academic for us. But when we're patient-facing. When we're in clinical practice, I think the modification is really what drives the person to do what they do. And it isn't because it's junk food is better or this thing, it's what they are attached to and what they're attracted to. So I really think that there's two components to it, that we really have to target their specific desire. You know, the guy that drinks whiskey, the businessman that drinks whiskey starting at 6 o'clock at night, or the alcoholic that's drunk in the gutter, they're equally alcoholic. And there are different patterns, but the end result is the same. Yes, helping that person to understand their pattern is important, but ultimately, by the time you've gotten to the point of severe harm and you're ignoring the harm to distort the reality of the relationship, which is addiction, and this is what a lot of people don't understand, is that, yeah, you're unlikely to get fat from eating apples. But once you are fat, eating apples perseverates that relationship, both biochemically as well as psychologically. And I think the clinicians need to look more at the psychology of what patients are doing rather than the biochemistry of what's happening on the inside. You will never, ever convince most patients to change because of biochemistry or some study. And I don't even own a white coat, let alone ever wear one in front of a patient, because we're just two people having a conversation and helping them to understand where they have the ability to redirect their lives. Because I can't do that for them. You know, one of the key things is a beautiful thing I saw on Instagram the other day, where a woman was talking to a doctor, and the doctor said, you know, we've got your blood test results, and these are all lifestyle problems. And the patient said, oh dear, does that mean I have to change my lifestyle? And the doctor said, no, here's a pill for it. And that, unfortunately, is the problem, is that, yeah, as a surgeon, I can fix obesity. I can get your weight down. I can get rid of your excess weight, but I cannot change this. So we have to partner up, and it's about the relationship. It's about helping people to understand that they have the capacity to change, not as a home run, but as little infield singles. So I sweep all the science aside. I can always bring up a scientific paper to validate and justify my opinion on a medical and a scientific basis. But ultimately, it's about relationships, and it's about helping a person to help themselves, and creating that motivation, creating that support, creating that positive feedback that is important in clinical practice.
Yeah, and I think that those are important points. I think really, when you look at it, Tro's brought this point up a lot, hyperpalatable foods. So if I give you a potato and some oil and some salt, you're not going to eat much of that. You're not going to eat a raw potato and just eat it. But if you make those into French fries with the same ingredients, you'll eat it all night, right? Or, you know, for me, like I ask my patients that, right, when they come in, I'll say, what's your kryptonite? What is it that is your killer, right? For you, it's M&Ms, right? I knew that. I know your story. So certain people, you say, okay, if you're an alcoholic, you stay away from the bar. Or if you're this, you know, so there's certain things that can be less addictive, I think, to that patient. Some people have a handful of nuts and they can't stop. They'll eat macadamia nuts till they throw up. I did that when I started. I'm like, oh, I'll just eat macadamia nuts all day, right? And then I realized, okay, this doesn't work.
The issue is you've got your preference, which might be M&Ms. But if someone's going to offer me a kiss, the chocolate kiss, I'm not going to say, oh, no, I prefer M&Ms. You know, if the alcoholic is a whiskey drinker and they don't have any whiskey, they're not going to say, oh, no, I'm not going to drink vodka. It doesn't matter.
But if I give you a raw potato, you're not going to go on this. You're not going to eat 30 raw potatoes.
No, but I'm going to bake it. I'm going to mash it. I'm going to turn it into French fries.
Exactly, because you're making it palatable.
That takes, right. Raw is different, but it doesn't matter if it's the baked potato or the French fries. That, to my mind, gets you down the pathway that most dietitians who are balanced people, or, oh, brown rice is better than white rice. No, it's not.
I think
apple's healthier than the donut. No,
and I think it's a spectrum, because I know, you know, your stuff with addiction, like a true addiction. A lot of people don't, it's not really an addiction problem. Sometimes it's a habit. They go, hey, every time I get home, I just eat pasta and I have that. And then they just go, okay, I'll stop eating that. It's not a big deal to them.
Right.
But some people, it's like they're jonesing on it. Yeah, exactly.
You've got use, abuse, and addiction. You know, if you have one DUI, it might be a mistake. If you've had 5 DUIs and you've got liver disease, that's not a mistake anymore. You know, if you've gained 10 pounds, that's a little bit of sloppy laziness. Cut back a little bit. If you're 300 pounds when you should be 120, that is no longer, you know, so the point is we've got to understand our patient population. And I see lots of people who say, oh, I'm addicted. I gained 5 pounds last week. No, you're not. And it doesn't mean I can't help you with an abusive relationship, but an abusive relationship does not need abstinence because you've still got a vestige of control. An addiction, you've lost control. And as somebody said a little bit ago, you may be good on a good day, but it's the bad days that count. And if you've got easy access and you haven't transformed that relationship, that's problematic.
Dr. Loh, what do you see on that? As far as patients coming in, if you're starting someone on a low carb, like how do you start them? Do you say, hey, zero tolerance, or do you say, hey, let's try to get rid of the low hanging fruit first and then kind of ease in? You know, what I'm getting at is some people will get in really slowly into the pool. Other people just jump in and get it over with.
I mean, I do see a lot of addiction, and I've been doing obesity medicine for over 20 years. So we start hardcore because I think this little, you know, dribbles of removing this and that, clearly, just for me in my practice, and maybe different for other people, I find that you have the least results with that, and then people get discouraged very easily. Obviously, we have to handhold them through the earlier, you know, the first week and so forth. They get through that. It's a little easier. I'm sure everyone knows that. But I think we do need to recognize that, you know, with brain insulin resistance, that, you know, we lose the satiety effect, right? We lose the anorexigenic effect of the insulin, and also with leptin resistance, we see that. And just in the context of ultra processed, shall we say, carbs, we do know that fructose in particular does that it will just blunt that satiety center in the brain. And it also seems to not, well, it seems that usually your ghrelin levels after eating should drop. But with fructose, we don't see that drop as well. So there are clearly, you know, changes hormonally. And sometimes I find that explaining it to the patient gives them a little bit of added motivation to stay on it, especially in the beginning. So while I recognize that behavior is a huge part of it, oftentimes just giving patients, you know, the rationale for what we're doing, just, you know, makes it a little easier for them, and, you know, makes them a little bit more motivated to get through those first few weeks.
Yeah, you know, for me, I think I'm exactly the same way. My approach is this: look, you're paying for this. Let's do it. Let's jump in. Let's do what we can do. If you're hungry, okay, eat, but cut the carbs, right? And as much as possible. Here's the deal. Look, it's the fear of not having that. So if I'm addicted to wine, I go, okay, let's cut the wine for now. If in a year you have the best bottle of wine and you want to have a glass, let's look at it then. But the more, maybe that's not the best example. Cook bread. So I tell them, they go, doctor, you never eat bread ever. And I go, well, I never eat bread, but if I go to Ignacio's place and he makes a homemade bread, I might have a piece, right? But I have one piece a year. I'm not having it 10 times. But the more you go without it, the more I find when I go to Ignacio's house, I go, you know, I really don't want the bread, Ignacio. I'm fine. Is that okay if we have something else, right? So, and a lot of people they think, and I think this is an important point, because we have to live lives. We're dealing with people in real life who have stressors and all this stuff. We're not in the lab. That's why I don't like lab studies. That's not what we are. So, you know, people figure out, they go to mom's house and she insists they have a piece of pumpkin pie. And well, I really don't want that. Or they, you know, or the patient will say, well, I'm going to take my own alternative when I go. So basically having them have the tools not to be in a place where they have to eat that bad food, right? Some people self-sabotage and say, oh, I didn't have anything else, so I had to eat pizza. Well, you could have made you knew there was going to be pizza, you know, those kind of things. So, you know, a lot of times I'm so happy my patients will come and say, well, I knew I was going out right with the guys for the weekend. Usually we drink beer and chips and crackers all weekend. So I brought a bunch of ribeyes and they were jealous of me, right? We had a good time and I didn't have a drink and I didn't. So it's so great to see that. And I think with time that gets easier, but the problem is upfront, that fear. You know, we have a fear of being hungry. We have a fear of not being able ever to have that food ever again. So you're like, what's life worth if I can never have a piece of cookie or whatever again, right? If that's been their life all along. So, you know, and that's kind of and a lot of people feel better to go, okay, so if I want one down the road, I can have one. But then when that time comes, they go, I don't really need it. Or they have it and they don't like it. They go, it wasn't as good as I remembered. I had a guy who gave up soda. He was drinking 12 sodas a day, sugars through the roof. We got him off insulin. Everything's great. One day he had a soda and his sugar went to 300. He's like, it didn't even taste good. Why did I do that? Right? And he stopped himself. I didn't have to tell him, but we saw it on the continuous glucose monitor and I asked him about it. So, I think that we have so many tools available now also that are so helpful.
But I think, Brian, I hear what you're saying, but there is not a single other addiction. There's zero other addictions on the face of the earth that are managed with moderation. Why? If you believe that...
No, I agree.
Why not? So that's the first thing, because you can't break a habit that you're still doing. But the second part is this: inherent to addiction is relapse. And I think with diets, the failure is a relapse, because this diet didn't work for me. I'm going to go on this one. I'm going to go on this one. If you're a smoker, expect to relapse a few times, but learn from each mistake and do the same thing over and over again. What people don't understand, they treat keto like a diet. Oh, well, keto didn't work for me. Well, I lost a lot of weight on Atkins, but it didn't work. So now I'm going to try the cookie diet. I'm going to try Weight Watchers. So they bounce from diet to diet to diet because they think the problem is calories. The problem is not chronic excessive caloric consumption. It's chronic excessive carbohydrate consumption. But the conundrum is this, that any form of caloric reduction results in weight loss. But only carbohydrate abstinence sustains weight loss. And that's the conundrum that people don't understand, because we're still preaching diets. And if you treated any addiction like a diet, 100% of people would fail.
Well, and I think that's kind of what we're getting at. It has to be a lifestyle. So it has to be something you can sustain forever. So here's the question. You have some people who quit alcohol. They can have one glass of wine a year, and their wife says, on Christmas Eve, we have a glass of wine. We're going to control it. That's it. No more. And then they have no problem. Other people have one glass of wine, and they're an alcoholic, and they're in the gutters the next morning. So I think that's the point. It's an individual thing. Some people can moderate and have it every now and again, and then they're fine. Other people have it, and they go off the rails for a month, right? So if you're that person,
I do think, Brian,
zero tolerance.
You've got to take the concept of time into the equation as well. When you quit smoking, it's, oh my God, I need a cigarette. And then over time, you need it less and less. And 5 years later, that's disgusting. How can anyone smoke? Because they've been abstinent. You cannot break a habit that you're still doing, because
Correct.
Distance and time allows your brain to forget that as a trigger. There's still a vestige of muscle memory. And especially, that's why we preach the effort-based emotion management system. If I run every day, I'm much more likely to go for a run when I've had a bad day than go back to eat ice cream that I haven't eaten for 20 years. But if I'm having a little bit of ice cream every day and I'm having a bad day, that's where I'm going. So it really is about changing muscle memory. It's about changing the foundation of who you are. And it's a very deep, complex thing. And I know you're going to find the isolated people that do well for a while. But I'm in my late 30s right now, which means I have to go for 70 years if I want to live to 100. That's a very, very long time for me to have that little relationship that I control. But if I abstain from it, it's not an issue for me.
Let me make sure I clarify what I'm saying. When I talk to that patient on the first visit, I'm not saying you can never, ever have bread again. What I'm saying is like, look, if there's a situation that rises up in a year or 3 months or 5 months, at that point, so I'm buying that first couple months, and once they're in, they go, yeah, I don't really need it. So I'm saying once you get them mentally right, but at that first age, they're like, oh my gosh, this is overwhelming. I can't have cookies. I can't have Coke. I can't have a beer. I can't do this. Oh my gosh, I can't do it. So the failure rate.
Vyvyane and I may disagree a little bit. My authoritarians can jump in the deep end of the pool. There's no way my permissives can.
Exactly.
But what we're arguing about now is more, or discussing right now, is more methodology than concept. I think the concept is true, and the desire fades over time. So you don't say you're not allowed to have cookies forever. It's let's go a few days without cookies. But I just start with liquids. Some people, as I said, can jump in the deep end, but biologically and psychologically, that's very, very difficult to do. Whereas if you do it by category, for example, my first category is no calories in anything you drink. And then we move to how do you eat, and then maybe snacks, and then maybe, so it's categorically. The other concern I have with coming out of the diet philosophy into the addiction philosophy is this: nobody ever tells an addict what they should have. It's all about what they should not be doing. And yet especially in the dietary space, we love to tell people evangelically what they should be consuming. Don't consume sweeteners, don't consume this, don't have that. I don't care what somebody consumes as long as it's not carbohydrates to begin with. And then we can refine things down the road. If you make it too rigid because you are authoritarian and you try to impose that on your patients, they're going to crash and burn.
All right, sounds good. Maybe we could just jump through a quick couple questions they've been waiting. Grass-fed versus whole grain. The world expert on this is Peter Ballard. Said he has tons of information on it. To everyone's great consternation, he said there's really no difference. If it depends on your finances, whatever you can do. So that's his take on it, and I consider him the expert on all this kind of stuff. So it really, the interesting science on it is the difference between pigs eating, when they're eating a lot of monounsaturated fat, if they're feeding them like soy, whatever, they're not able to digest that, and they store it in a different fat form than a cow can because of multiple stomachs. So it's kind of really interesting science. So ultimately, it does not make that much of a difference, despite what everyone says. And then there was a question about pesticides in the foods and food chemicals, causing some of these problems. Anyone want to take a stab at that one?
I mean, just that, we have to also consider our gut microbiome and, how that might interact with the gut microbiome via various pathways. Clearly, I don't think anyone would willingly ingest pesticides, right? And it's not a matter of, it's just this one time. If that's a consistent thing over time, then your load over your lifespan is going to be much higher. And if you're looking at younger patients, smaller body sizes, those that might reach a more sort of toxic level sooner. So I think with pesticides, I think the big worry is how it impacts the gut microbiome, aside from maybe other, toxic effects to the body.
Ignacio, there's a question. This is one that comes up, and this is one I've considered also. Do you think there's any benefit of using exogenous ketones for Alzheimer's disease or Parkinson's, things along those lines? And would coconut oil be just as effective?
I don't know of any hard evidence on it. I've heard about some. The question specifically addresses MCT or exogenous ketones versus coconut oil.
Yes, or if there's a benefit of just, I think the problem we're seeing right now is if we have a senior who's demented, and we say, okay, like it's really it's a difficult because they're used to eating donuts and cake all the time. Now all of a sudden it's like, okay, they're demented and you're trying to change their diet. It's kind of a brutal proposition a lot of times. So they say, well, maybe you could just add ketones to their diet and see if that helps. If their brain there is some data on the brain running better on ketones than glucose.
Yes, in an environment, in a metabolic environment, in where first it is also of course advisable to reduce as much, because these are very, very distressing patients to take care of. So we might find a caregiver that might be diligent with diet, but if it's not a severe cognitive impairment, and if it's in its early stages, and maybe in someone that even has a history of metabolic disease in their family, I would for sure consider the possibility of trying it out, trying exogenous ketones, trying something along the lines of having coconut oil during fasting times. And that is one of the areas of investigation that is advancing the most. There's a lot of evidence about the ability of the ketones to kind of like, not, I wouldn't say compensate, but it gives a great fuel for those brains that are already insulin resistant, specifically in the blood-brain barrier. So I do not specifically, I don't know of evidence about coconut oil, but if you have a good quality coconut oil and it preserved all of its quality, I think that it's no reason to probably try it out and check for the ketones if that's a possibility.
Dr. Loh, do you have any experience?
Not directly, but when I have patients who have parents who may have dementia or cognitive impairment, I certainly do suggest it. And my preference is just to use straight C8 because you do get higher levels of ketones. Sometimes with the coconut oil, I'm not so sure, but with the C8s, I do see that we can get, therapeutic levels of ketones. So usually if they're trying to impact cognitive impairment, then I will ask that they get the C8 specifically.
Yeah, and I think these are all important points, and and I don't think we have a lot of data. I've tried a few times. It is a hard thing to get a senior on a ketogenic diet. Dr. O'Meara's data is impressive with increased nitric oxide, increased blood flow to the brain, all these kind of things with decreasing visceral fat. They're all connected. And just anecdotally, I think one thing that I think, and Jason Fung has mentioned this too, is ketones may be a last-ditch effort. The ketones, like if you're starving to death, ketones go up, and because you're trying to go kill something or you're trying to survive. And so when people are dying, sometimes they'll have this moment of lucency or aha. They just wake up and they're in a coma, and they wake up and say, "Oh, make sure you pay the bills. Call your brother, do this stuff," and they're like out again. So we're thinking that may be this severe ketone effect that just wakes up, that they get this flow to the brain and energy, but that's all speculative. I don't know that we have data on that, but we do see that clinically. And it makes sense, that if you're dying, that's your last chance to try to survive. So say bye to your family, all that kind of stuff where you're coherent at least. And, so there is data on that. I mean, there's
I just
speculation on that.
I was going to say, if it were me and it was my last moment of lucency, I would say, make sure you don't pay the bills, please.
Yeah, don't pay the bills. Yeah, forget it. Yeah, don't worry about it. I think that's how we ended the conference, Doug. Don't pay the bills, Doug. Hey everyone, thanks for sticking with us. This is great discussion. It was really great. And Doug, thanks for all your hard work. Great conference, great people, great speakers. So we will we'll leave and we'll relinquish control back to you.
So I really apologize for all that drama. Hopefully you still got a decent amount of information out of what was working, or once it started working. And I think I just have to thank you all for being here and being a part of this and giving us a reason to do this. It's you people that get it and take it to your patients and your friends and your family and yourselves and fix things. That's why we do it. And I started talking at the beginning of the conference about Admiral McCraven's talk, which I'd played at a previous conference, talked about a couple of his lessons and took his whole theme of what starts here changes the world as our theme for this, actually for LowCarbUSA now, on an ongoing basis till I find a better one. I think it's awesome. So I'd just like to finish off the way I did the last conference and basically regurgitate, I suppose, his summary of the lessons that he highlighted in his talk. It says, start each day with a task completed. Find someone to help you through life. Respect everyone. Know that life is not fair and that you will fail often. But if you take some risks, step up when the times are the toughest. Face down the bullies, lift up the downtrodden, and never ever give up. If we all do these things, then we will leave this world a far better place than we found it. And what started here this weekend will absolutely change the world. Thank you so much for being with us, and I really hope that you join us next time. Good night.